Hi everyone, this is Joe Smith again, the MICU Director at the Rowdebush VA Medical Center. This video is an orientation to working on pulmonary consults as a pulmonary and critical care fellow at the IU School of Medicine. Again, as in my ICU orientation video, the best part about working at the VA hospital is that you get to take care of our country's heroes. For the most part, our heroes, compared to other patients that you may take care of, will complain less. They don't take your assistance for granted. They really need your help. They're grateful. They're very happy to just talk to someone, and often will even talk your ear off, and they're appreciative and thankful. I've given you important phone numbers via the survival guide, which is available online, but they won't be in this video since it's published on YouTube. Your duties when you're at the VA as a pulmonary and critical care fellow will be to act as one of either the pulmonary fellow or the MICU fellow. So you know, the pulmonary fellow rotation at the VA MICU is a vacation eligible month. But when you do take vacation, you will need to, number one, make sure the attending and the MICU fellow are aware that you're going to take vacation. And you'll also need to let the pulmonary function test and home oxygen test technicians know that you're going to be off so that they can send the studies to the MICU fellow while you're gone. Also of note, I have not included information on covering the ICU in this video, so I'd recommend that you watch the ICU orientation video to prepare to cover both services when you're on overnight or on the weekends as a consult fellow. Obviously, your duties as a consult fellow are to see consults, but at the VA, the pulmonary consult fellow and the ICU and pulmonary attending are responsible to see both inpatient sleep and pulmonary consults. I ask that you write your notes on the same day as the consult. There may be rare times that a consult is received overnight that will not be staffed with your attending fully until the morning. In those cases, I still ask that you write the note the same day as you see the consult. Daily notes on your patients need to be written when you're going to see the patient with the attending. There may be days that you see a patient only through the electronic medical record to check on labs that are pending, and you won't see the patient yourself or with the attending. On those days, you don't need to write a daily note. You're also responsible for interpreting and completing both pulmonary function tests and home oxygen evaluations. Please see the separate orientation as to how to do these in a third video. And finally, you'll also be responsible for doing outpatient bronchoscopies and any inpatient consult bronchoscopies that come up. One important thing about doing the outpatient bronchs is that your notes must be completed at the time of the procedure. This is a Joint Commission requirement. There is an additional video on how to set up bronchoscopies and a fourth video available on YouTube. Just so you have an idea of what we have available in the bronch suite, we have basic bronchoscopy, we have EBUS, navigational bronchoscopy, APC, cryo, foreign body retrieval tools. We rarely do stents, and we are working on getting into bronchial valves. The consent process for procedures at the VA is similar for whether you're on at the ICU or in pulmonary consults. Essentially, you use IMED consent for all consents done in person or on the phone with a patient or family. If IMED consent is down. There are paper consents in the ICU team room. If a procedure is emergent and the surrogate is unavailable or there's no time to consent the surrogate, you would complete the procedure or the transfusion, then complete the procedure or transfusion note as appropriate, and then add Joseph Smith, myself, as a cosigner. Please call the family afterward in these situations to notify them that the procedure was completed. For non-emergent procedures with no available surrogate and when the patient is unable to consent, please call the ICU attending, who will contact the medicine service chief. You can also look in the VA directive, the national directive, to understand more details of this process. A brief note on curbside consults. Curbside consults are generally much more complex than you can answer without further evaluation, and many times if you simply answer the question that they're asking as a curbside consult, you may be answering wrong because you don't know additional details on the patient. The best practice is to see the patient and write a full consult note. Finally, refusing consults is not okay. If you find yourself in the position that you're considering this, you should talk to your attending, or if it's happening on a frequent basis, talk to me about inappropriate consults. In the end, we're there to help, and if you think a consult is overly simplistic or the answer is obvious, you can always work with the team by educating them rather than refusing their consult. Pulmonary outpatient consults at discharge. So when you're seeing a patient in the hospital and your attending feels that they need an outpatient follow-up, or you feel that they need an outpatient follow-up in pulmonary clinic, it's your responsibility to be sure a pulmonary outpatient consult has been entered into the consult tab of CPRS. The primary team is generally the team that should do this, but if you're unable to get them to do this, in the end, I would rather you put the consult in yourself than have the patient get lost to follow-up. In the consult note that you're writing on the patient, you can also indicate who and when the patient should follow up and add our pulmonary nurse and pulmonary schedulers as co-signers so that they can make the appointment. This is in addition to writing a pulmonary outpatient consult order. Those two folks are Sarah Enochs and Rebecca Polson. When you have a patient that is already followed by pulmonary as an outpatient, they may not need a pulmonary outpatient consult, but rather just a note to Sarah Enochs and Rebecca Polson so that they can get them scheduled for a follow-up appointment. As far as consult documentation, the most important and rate-limiting step is asking the team that asked for the consult to enter a pulmonary inpatient consult electronically in the electronic medical record. If that is not done, you won't be able to link your note to that consult, and the VA won't be able to monitor a services consult volume. When you write your note, you'll be asked to complete the note as well as the billing for that note. Please follow the guide in the team room to ensure you use the correct note and complete all coding requirements. This includes both new and follow-up patients' notes. As far as call, just like the ICU, the call is week on, week off, beginning on Friday morning to Friday morning. The call is home call, and the call person shares both the pulmonary and the ICU services. You really need to come in to help the resident when needed. Residents rarely ask you to come in directly. You have to hear it in their tone and know their comfort level during the day to know when you need to come in. As far as consult-related calls overnight, most of the time you can make recommendations over the phone and then see the patient first thing in the morning. However, there are some consults you need to come in for. The most common would be chest tubes with an urgent need such as a pneumothorax, an empyema, or a complicated parapneumonic effusion. There will be other times that you may have pulmonary consults that you need to come in for, but many times if there's an urgent need for a pulmonary consult in the middle of the night, these patients are often better served by being in the ICU. If you're uncomfortable with a procedure or a patient, no matter if you're on pulmonary consults or ICU, please call me or your attending. But if you can't get a hold of your attending for some reason, call me. You can do this day or night. Not calling to get help is a much worse decision for you and for our patients. And finally, thank you for taking care of our vets.